Hello, I'm sharing a sigmoid resection for presumed diverticular disease and a colovesicular fistula. This is in an individual who never knowingly had any episodes of diverticulitis. Interestingly, the patient, for different reasons, has renal failure and is on dialysis, so noted no urinary changes, but was getting infections, cystitis. He was not able to get a colonoscopy prior to surgery due to concern on the part of the gastroenterologist, and so surgery first approach was chosen. I'm just showing that I like to go over and see the ureter before I will divide the vasculature. In this case, it's kind of an oncologic resection in the situations where the patient has not had a colonoscopy, although for benign disease like this, I still do prefer to do a medial to lateral with a high ligation. I find that the retroperitoneal planes tend to be unviolated and easier to dissect in these complicated cases. We'll now go and do some lateral dissection. With a good medial dissection, you should be able to find your lateral dissected, join the planes rather easily. In this case, I did not really go far out above the ureter, but you saw that I did expose the ureter. I usually put a sponge down there. I didn't in this case because I can see the ICG so well, but as long as I stay on top of the ureter right here, I should enter into the previous plane, and you saw it right there. So now I'm going to go down towards the pelvis and try to take down the adherence of the fistula. There's some adherence to centrally around the dome of the bladder, but there's also some adherence towards the left and closer to the trigone than it looks. So I'm really trying to hug the colon and staying away from the lateral pelvic sidewall. I find that ICG in the ureters is extremely helpful for cases like this. We'll now go and attack the fistula from a central anterior position. You can see ICG leaking from that area, so you know that that is definitively the fistula from the ICG that was placed into the catheters and now leaking with the urine. And just slowly coming down and around this, and I'm trying to get the fistula to come to a point because I certainly don't want to inadvertently be dissecting around inflammatory rind thinking it's the fistula and get too close to the ureter or some other critical structure. Right here, I believe, is the actual fistula tract, and I'm just trying to cone in on it because you can see how close that left ureter comes to where my suction device is. Right there is the hole into the fistula. Nothing appears malignant, nor did it appear that way on the cystoscopy when the stents were placed. And I'm just trying to get the rest of this adherence down so I can completely restore what I refer to as normal anatomy. And there I was able to connect. So now I'm going to know that my ureter is going to be well safe as I choose my distal margin. I'm looking at my reach here, looking at my planned margins. Here I'm dividing distally. In an individual who has not had a colonoscopy and the specimen is too large to be removed as a single piece, I will not morcellate it, and I'll do a standard fan and steel incision extraction, which is what I ended up doing in this patient. But for right now, I'm just going to go ahead and clear the mesentery to the proximal and distal margins. I did go up to the splenic flexure with my mobilization here. It was not necessary to take the flexure completely down. He did have some weird adhesions up there that were kind of confusing, but it didn't change any tension by having not taken it down, so I left it. This is taking the proximal mesentery. And then when we're ready to divide, I'm stapling here through arm number 3, which is a 12 millimeter port through the right rectus. And now we'll staple distal. Examining the reach, didn't feel that there was really much tension whatsoever. This is a practice that I do more commonly when I'm doing transrectal extraction of the specimen because I feel like it helps mobilize the rectum for easier extraction. But I'll also do this in cases where I just want to get a few centimeters of reach and decreasing tension. And this is, I think, another nice maneuver that you can do for reach in the opposite mobilization than going up and doing the splenic flexure. So I'm just mobilizing the rectum a little bit. I know many people routinely do this down to the floor for benign disease. I don't usually, other than, again, in natural orifice extraction, but in this case I chose to do it for the lengthening maneuver, because you're going to see after doing this how easily the rectum comes up towards the sacral promontory. I will leave the anterior peritoneal reflection alone. And now I'm going to sew my anastomosis. So this is the back row of 2OPDS. You can see now how that rectum is up and above the sacral promontory, where before, after stapling, it looked like it was retracting down below the bladder. So that little mobilization maneuver there really helps out for, 2, 3, 4 centimeters. And in my humble opinion, it can be easier than going up and mobilizing the flexure. I'm not trying to say that it's an alternative to, I'm just saying that it's an adjunct in mobilization. We'll check ICG after we've made our proctotomy and colotomy. I like to show here how that mucosa on the inner lip is still enhancing sometimes in some of my videos. That inner lip, either on the colon side or the rectal side, does lose its blood supply after making that colotomy, and I will revise the anastomosis if that happens. This is just showing how I like to sew out to the left when we get started, and then I sew another one out and around the right. I tie those two to the center together up over the top, and then we do another layer of 2OPDS. Just bringing it all the way around to the original tie on the posterior side, so that when these two are tied together, it's truly circumferential. You see the interplay between my two left hands to aid in keeping the suture tight as we go. This is not a barbed suture, which is why I take the time to use the two hands to keep it tight. After this, we'll just do our leak test. And now we'll test the bladder and ensure that the hole does or doesn't need to be repaired. You saw a little flash of methylene blue right there. You saw the ICG leaking from before. I'm still doing this as a formality. I think it's good practice to get used to this and to see at what point these holes can open up, because now I'm saying, hey, well, maybe if there was just that tiny little hole, maybe I don't necessarily need to go ahead and repair it. But you'll see on this next push, boom, it busts open. So I'll clean everything up, and then I'm going to put stitches there. You do have to be careful. This is very close to the left ureter, maybe 1.5 centimeters away. We didn't do a biopsy during the cystoscopy, so I chose to just get in there and get a little of that mucosa on the inner lip of the fistula. I'm not going to take 1 centimeter or anything all the way around, just that tiny little bit, which was expectedly benign. And now I'm going to close this kind of in 2 layers. This was a running 6-inch V-lock that grabbed mucosa and now is grabbing kind of the seromuscular. And now I'm just going to do a big figure of 8 to a PDS, grabbing and lemberting all of this tissue over the top of the repair. In these cases where I do a bladder repair, I will leave a drain in the belly, and I will leave a Foley for 5 days, and I will get a study. When I don't identify a hole and I don't repair anything, I just leave a drain and a Foley for 48 hours, and then I just remove the Foley. Here we go ahead and we test again. This time there was no leak. I like to interpose the fistula site to the anastomosis, much the same if I do a transvaginal extraction. I like to oppose that from the suture line, and when the omentum reaches rather easily, I'm just going to use that. So I had some extra V-lock here from the bladder repair, and I'm just sewing a flap of omentum down into the deep pelvis. I did not need to mobilize this off the transverse colon. It kind of just went on its own. But I will mobilize the omentum up off of the transverse colon on the left or the right, preserving an arcade pedicle for the blood supply, to do what you're seeing me do here. So this is going to completely interpose the space between the anastomosis and the bladder repair. I have had a patient in the last few years where I did a repair like this where I had no omentum to interpose, and within a year they had a recurrent fistula to my anastomosis. So I do believe in that maneuver. I hope you enjoyed.